Hi, everybody. So today I'll be talking about some work from my master's thesis, actually, which was about racism and discrimination and in the disparities of hypertensive disorders of pregnancy in the United States. Okay, so hypertensive disorders of pregnancy are a leading cause of maternal death in the United States. And 31.6% of those that were hospitalized for delivery that died were diagnosed with a hypertensive disorder of pregnancy. And Black women, unfortunately, are 2 to 3 times more likely than non-Hispanic white women to die from a hypertensive disorder in pregnancy, or HDP, as I'm referring to on the slides. And so in thinking about this disparity, I really started to think about how race is really a social and political construct, but we often use it as a biological indicator of health differences. And what we should really be thinking about is really what is causing these differences, or what's kind of influencing what we're seeing in terms of negative health outcomes, and that's exposure to racism itself, not the person's race. So this brought me to thinking about, in terms of quantitative modeling, similar to like what we were just talking about in AI modeling, how do we account for racism and discrimination in this modeling to see how that affects health outcomes. And so to do this, I looked at the CDC PRAMS dataset, which is the Pregnancy Risk Assessment Monitoring System. And this dataset collects data on maternal health experiences. And the goal of this dataset is to reduce infant morbidity and mortality. And so this dataset collects data from different sites in the US, so states, cities, US territories, and all of these, this entire dataset makes up 81% of live births in the United States. And the data that is collected via questionnaires given to people that have recently given birth, and ask questions from anything from did you get a flu vaccine to did you have social support during your pregnancy, things like that, and also has birth certificate statistics, so something more quantitative as well. And so thinking once again back to this health equity lens and how this may affect health disparities in terms of hypertensive disorders in pregnancy, I hypothesized, one, that there will be a higher risk of hypertensive disorders in pregnancy in those who experience racism and discrimination. And secondly, if we control for racism and discrimination, meaning we standardize that across the model, this might reduce racial and ethnic disparities in these diagnoses. And so in looking at the data set, what we had was a subset of the data, because at the time with this PRAMS data set, not all states were required to ask about racism and discrimination. So we only had 17 sites that did. And when asking about discrimination, there are different factors that they were asking about, not just race, but also things like insurance status and sexual orientation. And so in the end, what we had was a data set of 9,907 live births. And 18% of the participants stated that they were diagnosed with a hypertensive disorder in pregnancy. And non-Hispanic Black individuals did have the highest rate of that diagnosis at 21.8%. And so in looking at the model that we had, so we controlled for various risk factors that are all listed right there, that are risk factors for hypertensive disorders in pregnancy, so from a biological standpoint, but also a socioeconomic standpoint. And so in terms of looking at the data, so we have this data set right here, and so the factors that I showed in the box are controlled for. And so in the first model, that is the race and ethnicity model, that was kind of our control. So seeing if we controlled for all of these factors in the box, do we still see those disparities in our data set? And we did, because the Black women were still at a higher rate or higher odds of developing hypertensive disorders in pregnancy. And then secondly, after that, we looked at 2 questions. One, if we include perceived experiences of racism and discrimination, do we see an association with hypertensive disorders in pregnancy? We did not, because it's not in bold, so that means that there's not a statistical significance there. But what we did see is that when we did include this in the model, we saw that the disparities for Black women was now not statistically significant. So what that means is that that was reduced. And so overall, what we found was that there was not a higher risk of hypertensive disorders of pregnancy among those who experience racism and discrimination. But when we did see that we controlled for that, so we standardized that across all of the races, we saw that there was a reduction in the racial and ethnic disparities in HDP. And so what this means overall is that experiences of racism and discrimination drive racial disparities in hypertensive disorders in pregnancy. And what this means for all of us as innovators is, one, we need to think about how we can include things like social determinants of health, racism, in predictive modeling, because that's often done for these types of conditions, for seeing if someone will have preeclampsia or another hypertensive disorder in pregnancy. Secondly, we should also see how can we look at, biologically speaking, the effects of racism and discrimination on people. Are those why what we're seeing? Is it all strictly due to someone not being able to access care or something like that? And lastly, in general, we should need to think of how we can reduce racism and discrimination in all settings, because they are a driver of racial health disparities. Just want to thank everyone that participated in the study, and also that helped with the manuscript, and I'll take any questions.
Thanks so much for the great presentation. It was really interesting when I was looking at those risk factors. Those are the same kind of eligibility criteria for low-dose prenatal aspirin. Did that show up in your work at all, whether people took that prenatal aspirin, or did it factor into the data set in any way?
No, for this data set, no, it did not. But I know that when people are trying to detect if they want to use some or give someone aspirin, they do a predictive modeling and kind of take those things into account. So yes, this is kind of what partially motivated this work too.
Great, thanks.
Thinking about a question that someone asked earlier today, and especially around the role of AI in the future of health innovations, how do you see that being impacted, race or diversity or other factors impacting in AI and how it's used in applications that impact women of color? As a Black woman here in the U.S. who's experienced these outcomes you described, how do we use AI in a way so that it's beneficial to us?
Yeah, I think with AI, what it comes down to is it's really as good as the data that we put into it, right? And so we really have to think about how we can try and make that aspect unbiased, and how we can kind of also influence other, kind of bring in other things, right? Because with this specific issue, what kind of also motivated the work is thinking about, when you look in the data of like why are there health disparities in this specific condition, it's all about obesity and like diabetes and things like that, but you're still seeing the disparities even if you control for that, right? So it's like we really need to bring in kind of other aspect of racism and discrimination and kind of these other social considerations. And so I think if that's possible to add into AI models, that would be something that would really kind of help figure out, okay, we really need to focus on really reducing this, whether that's training or something like that, to help kind of reduce that in that sense, because it's not clearly about the obesity, diabetes, or whatever the condition might be. So,
Excellent. Thank you. Appreciate you.
Thank you.